Welcome back to Ironwood Cancer Insights. My name is Kayla and I'm your host with Ironwood Cancer and Research Centers. September is Thyroid Cancer Awareness Month, and today we are joined with Dr. Davis Romney. Thank you for being here.
Hi, Kayla, how are you?
Good, how are you?
Doing great, excited to be here.
So Dr. Davis Romney is a radiation oncologist who specializes in head and neck cancers, which also includes the thyroid.
That is correct.
So to get started, can we just maybe start with kind of what is the thyroid and what are the functions of the thyroid?
So the thyroid is part of the endocrine system, endocrine or the glandular system, hormonal system of the body. It's a gland that's located in the neck, right in front of the trachea. It is primarily responsible for metabolism. It has some other functions as it relates to calcium levels and calcium control, but primarily metabolism. So, energy and calorie consumption and things like that. So if you've heard of folks who have hypothyroidism or low thyroid, they can be very fatigued or they can gain weight, and have those kinds of side effects. Or folks, if you've heard of having hyperthyroidism, they can lose weight and be overactive or have the bulging eyes if you've seen that. So those are some potential conditions of the thyroid. And then of course there's always cancer that can develop, like cancer can develop in any organ in the body, cancer can develop within the thyroid as well.
So when it comes to symptoms of thyroid cancer, what can people experience?
Great question. Very often there's a fullness in the neck. You could have a swelling or a lump that you could potentially palpate. Sometimes it could cause hoarseness. It could affect your voice box or even your swallowing. You could feel like food is getting stuck here, or really just kind of a raspy or a hoarse voice in conjunction with some level of swelling or a lump that you might feel there. You could feel it yourself. You could potentially have someone else notice it and inform you, or your doctor might even notice it on a physical exam.
So when it comes to a diagnosis with getting tested for thyroid cancer, what does a workup kind of look like? What steps go into that?
So once there's any suspicion of thyroid cancer, the primary imaging test is an ultrasound of the thyroid. The ultrasound can identify abnormal growths, masses, or nodules within the thyroid, and it can potentially, give a hint as to whether those nodules appear benign or malignant. You actually get a score on that ultrasound as to what the likelihood of suspicion of malignancy is. And then if it's suspicious for malignancy, then a biopsy would be recommended, which is also typically done under ultrasound guidance. They can localize a nodule with ultrasound and then stick a needle in it to obtain cells, obtain tissue, and then look at that tissue under a microscope to determine if it is cancerous or not.
Gotcha. So when it comes to that score, is there like a middle ground where maybe it's benign at first, but it could develop into cancer?
What a great question. So yes, so you could have, like say, the score ranges from a 1 to, well, technically a 6, but usually a 1 to 5. And 5 is highly suspicious and 1 is benign. Let's say you had a score of a 3, and it's kind of a middle ground, which is maybe, in most cases, a 5% chance of being cancer. And so you might choose to watch a lesion that's a TIRADS 3 and do an ultrasound in 6 months or do an ultrasound in a year to check on its size to see if it's changing its shape, if there's now calcifications within it or anything suspicious, and then choose to do a biopsy later. Another thing that can happen is you could have a biopsy of a nodule that's inconclusive. That's very common actually. When you're just taking a tiny little needle and getting a few clusters of cells out of a thyroid nodule, it can be difficult to know what you're really looking at. So one of the advances in thyroid cancer detection is what's called genomic testing, where they can actually test the genomic sequence within those cells that can look for alterations, genetic mutations that could then influence our suspicion of whether it's cancerous or not. One of those is like a RET mutation or a BRAF mutation. And if those exist or are present within even a kind of middle ground nodule that's inconclusive, that could up that diagnosis to maybe 90 or 95% chance of being cancer, and then basically confirm the diagnosis, and those folks would then move on with surgery.
Oh wow, it sounds like there are some great advancements coming.
Absolutely.
So when it comes to treatment options, say somebody gets diagnosed with thyroid cancer, what's next? What do their options look like?
So the primary treatment for thyroid cancer is surgery, and it's surgical removal of the thyroid, or what's called a thyroidectomy. However, there are multiple different types of thyroid cancer, although they're generally divided into two subgroups: well-differentiated thyroid cancers and poorly differentiated thyroid cancers. Well-differentiated thyroid cancers account for most of the cancers that we think of when we think of thyroid cancer: papillary carcinomas and follicular carcinomas, with some other variants that exist there. Those are generally well-treated, easily treated cancers with good prognosis. So usually, you remove the thyroid and that takes care of it for a lot of people. Sometimes radiation will get involved after surgery to try and help reduce the risk of a recurrence as a prophylactic type of treatment. And then folks with aggressive thyroid cancers or poorly differentiated cancers might need things like external beam radiation or chemotherapy or immunotherapy to treat their more aggressive disease.
And then to go along with treatment, are there lifestyle changes or lifestyle things that people can implement into their lives that can help after surgery or after diagnosis?
Certainly, as a general rule, we recommend a healthy diet and exercise. That's for all our cancer patients, really across the board, and it's no different for thyroid patients. The other issue with thyroid is once you've removed it, you have to undergo thyroid hormone replacement for the rest of your life. And so there are things that go in conjunction with that. They have to see an endocrinologist, they have to get their blood levels checked, and it's really important to maintain healthy thyroid levels because if you don't, it can actually increase the risk of the cancer coming back. So the biggest and most important thing that a patient can do after they've had surgery for thyroid cancer is to maintain adequate thyroid hormone levels.
So with getting into treatment, I know you're a radiation oncologist. Can you touch a little bit on when a medical oncologist or a radiation oncologist would get involved when it comes to thyroid cancer?
It's a great question. Typically when someone is diagnosed with thyroid cancer, they're usually referred to a head and neck oncology surgeon first, because surgery is the primary treatment for thyroid cancer, and that's the initial treatment. That's usually what we see. And so they would be seen by the surgeon, they would have their thyroidectomy, and once the thyroidectomy is completed and we have the final pathology, then they're usually referred to me at that point, where we see and evaluate them to determine whether they're candidates for additional treatment or what type of surveillance they need. At that point, they're also typically see the endocrinologist, who's going to help them maintain their thyroid hormone levels after surgery. Again, like we said before, that's one of the most important parts of remaining cancer-free is maintaining adequate hormone levels. So once I've seen the patient, one of my primary evaluations at that point, especially for well-differentiated thyroid cancer, is to determine whether they would benefit from radioactive iodine treatment, or what's called radioactive iodine ablation, or RAI. This is done when folks are at a high enough risk of a recurrence that administering radioactive iodine can lower their risk of a recurrence. That's typically for patients with larger primary tumors, say greater than 4 centimeters, or who also have lymph node involvement. So if your lymph nodes are positive, if you have a large primary tumor, we also look at other adverse risk factors like extension of the cancer beyond the thyroid, what's called extrathyroidal extension, perineural invasion, multifocal disease, some of the other risk factors that can also be considered in conjunction with the size and lymph node involvement determines their risk of a recurrence. We also have to consider screening for metastatic disease. What are we going to do to make sure that the cancer was all removed within the thyroid and that it hasn't spread anywhere else? So all of those things need to be looked at and reviewed when we see the patient for an oncology consultation. Then for those folks who require treatment, there's quite a bit that's involved there. They have to undergo a low iodine diet for a period of 2 weeks to effectively starve their body of iodine. And then we have to check their blood work to see if their levels are appropriate for treatment versus administering a form of thyroid stimulating hormone ahead of them ingesting radioactive iodine. Once they've taken in the radioactive iodine, then they're radioactive, and we have to do safety precautions for them and their family so their family isn't exposed to excess radiation. And then after their treatment, we do a whole body scan to assess where the radioactive iodine went in their body. Did it go to their thyroid remnant? Did it go into any lymph nodes? Is there any evidence of metastatic disease? And then from there, depending on what those results are, further follow-up versus additional treatment down the road.
So it sounds like each patient has a really personalized approach when it comes to thyroid cancer.
Absolutely. And if you go back, it's interesting to look at the kind of the evolution of thyroid cancer treatment today because it's changed. We've learned over the years. So, for example, we used to do radioactive iodine ablation on almost all thyroid cancer patients. Almost everyone got high doses of radioactive iodine. And we've learned over the years that we don't need to do that. That there are a lot of folks who actually have a low risk of a recurrence that really don't justify or have a significant benefit from doing radioactive iodine. So it is a lot more personalized care now than it was even 15, 20 years ago.
That's really great for patients. It sounds like you can also get rid of maybe those other symptoms or side effects that would come from treatment.
Absolutely. Radioactive iodine, while very effective at killing thyroid cancer, does have potential side effects, including uptake in the saliva glands that can cause a permanent dry mouth, or what's called sialadenitis, which is an inflammation of the saliva glands, taste changes, dry mouth, nausea, fatigue, things like that. Plus the exposure to radiation. We always want to try and minimize radiation exposure for our patients where we can.
Yeah, most definitely. So when it comes to thyroid cancer, is there a reason behind why people get thyroid cancer?
So it's important to know some things. We can't always prevent every cancer. Some cancers are random. Some is just a mutation in the DNA. They're not all genetic. Less than probably 5% of thyroid cancers are caused by genetics. There are very specific genetic syndromes associated with certain types of thyroid cancer. If you're diagnosed, you need to be screened for, so there's potentially genetic testing for those folks. Of thyroid cancer, 3 out of every 4 patients are women. Why is it that women are more commonly affected by thyroid cancer than men? And it can have to do with the autoimmune nature of thyroiditis. So women are more likely to have autoimmune antibodies against the thyroid and develop chronic thyroiditis that can then lead to cancer over time. So, but why do women get that over men? These are active areas of research, and then there's some ideas about that. But for most folks, it's sporadic with no direct known cause that we can point to. Certainly radiation exposure at a young age. We can look at the data from the atomic testing and the downwinders. We can look at data from the atomic bombs dropped on Japan and rates of thyroid cancer in folks in Hiroshima and Nagasaki to know that that type of radiation exposure can also lead to thyroid cancer down the road. But that doesn't mean your average person was a downwinder or had exposure from that. Vast majority of the time, we can't point to any specific cause other than to say, here's these risk factors, So that's probably one of the most common questions I get asked when I see a new thyroid cancer patient.
Are there any other questions that people commonly have when it comes to thyroid cancer?
I think that people are they want to know what their risk of recurrence is. They're concerned about what the likelihood of the cancer coming back. And that's something that we can answer with evidence and statistics and data, based on the risk factors that exist for them from their pathology, from their diagnosis, from the type of cancer that they have. And we do our best to answer that. Sometimes those things are unknown, though. We could say, in the next 5 years, you have a 15% chance of a recurrence. And while that number may be valuable for statistics, for an individual person, it's not particularly valuable because for them, it's either going to come back or it's not going to come back. Cancer doesn't come back 15%. It either comes back or it doesn't. So it's a 0 or a 1. It's binary. And so while that information can be helpful to gain general knowledge over like a population statistic, it's harder for an individual person to understand and know what that really means for them.
Definitely. So it's really great that we're having this conversation during Thyroid Cancer Awareness Month. Is there anything that you want the people at home to know about thyroid cancer?
Yeah, I think overall, I would want people to know that thyroid cancer, for the most part, is highly treatable. It's highly curable. That modern technology continues to advance and improve. That while it's scary to have a cancer diagnosis, and certainly that's a normal response to have when you're diagnosed with cancer, to know that there's hope that we can deal with this in a way that offers you a chance of long-term control of disease with hopefully minimal side effects.
Well, it's really great to hear when it comes to a cancer diagnosis, I'm sure people get very scared. So it's good to know that there really is hope.
Yeah, I think so, especially for thyroid cancer.
Well, thank you so much for being here today, Dr. Romney, and having this conversation with us.
You're welcome, Kayla. Thanks for having me.
Yeah, and if you want to know more about Dr. Romney or about Ironwood, head to ironwoodcrc.com.